unmuted.
Yes, good morning and welcome you all for another edition of Online Anaesthesia Postgraduate Teaching Program and Zoom platform. It is sponsored by Acrola and hosted by AIIMS. We have successfully completed 2 months of teaching. At this juncture, I like to thank my supportive team and all my students. Today, we have an interesting clinical case discussion. Cardiac patient coming for non-cardiac surgery. We have 2 examiners, Dr. Kirubanand from CMC Vellore and Dr.Sri Priya from AIIMS Mangalagiri. We have 2 postgraduates from Thanjavur Medical College. Today's session will be coordinated by Dr. Rajesh. With a small introduction, I hand over the session to Dr. Rajesh. Dr. Rajesh, over to you, sir.
Sir, very good morning, sir. And good morning, very good morning and good morning, one and all. So today this is the second in our online teaching program. This is our second critical case discussion. This is related to a cardiac patient coming for non-cardiac surgery. The first session will be related to preoperative evaluation and optimization, and the second session will be a patient getting posted for hip surgery, hip replacement surgery, a cardiac patient. And we have 2 eminent moderators for this session. The first part will be moderated by Dr. Kirubanand. He is an assistant professor in Christian Medical College, Vellore. Welcome, Kiruba.
Thank you, sir.
And the second session will be like the patient with hip problem, like a neck of femur fracture or avascular necrosis, posted for hip replacement surgery, either Hemi or Arthroplasty or THR, how to do the case. So that will be moderated by Dr.Sri Priya from AIIMS Mangalagiri. Welcome, madam.
Thank you, sir.
The initial session will be a case presentation by 2 postgraduates from Thanjavur Medical College, Dr. K.Subasri and Dr.J.Indra Gandhi. Welcome, postgraduates. So we will start with the clinical case discussion, clinical presentation first, followed by preoperative evaluation and optimization, and then and how to do a case of hip replacement. Indra Gandhi, you can start with that.
Very good morning to everyone. I'm going to present a case on ischemic heart disease for total hip replacement. 65 years old male, former by occupation, coming from Ariyalur district, presented with the chief complaint of history of difficulty in walking for 1 month, history of left hip pain for 1 month, history of presenting illness, history of RTA on 14/1/2022, not associated with head injury, loss of consciousness, ear, nose, throat bleeding, vomiting, and history of sustained closed leg, left leg injury, no history of any other external injury following road traffic accident. History of difficulty in walking for past 1 month, and history of left hip pain, which is dull aching, aggravated on moving, relieved at rest for past 1 month. No history of pain and swelling in the other small or large joint. There's no history of chest pain, palpitation, leg swelling, abdominal distension, dyspnea on exertion, decreased urine output. There is no history of cough with expectoration, breathlessness. Before road traffic accident, he was able to do all his daily activities without discomfort. Past history. A history of breathlessness on exertion belongs to NIHA class 2 for 6 years ago, for which he was evaluated and diagnosed as ischemic heart disease. It shows a moderate elevated dysfunction, EF 38%, followed by he is on dual antiplatelet drugs and statins. On tablet aspirin 75 mg OD, on tablet clopidogrel 75 mg OD, on tablet atorvastatin 10 mg HS, and tablet isosorbate dinitrate for 5 mg OD. And there is no previous history of hospitalization for chest pain or dyspnea on exertion, and there is no history of coronary intervention done for ischemic heart disease. Is a known case of systemic hypertension for 15 years on tablet amlodipine 5 milligram BD and tablet atenolol 15 milligram OD. Is not a known case of diabetic mellitus, cerebral vascular accident, seizure disorder, rheumatoid arthritis, thyroid problem, COPD, bronchial asthma, tuberculosis, rheumatic heart disease. Treatment history: it took native bandage treatment for left leg pain for past 1 month. Personal history is consumes non-vegetarian diet, normal bowel and bladder habit, is as normal sleep pattern. He is a chronic alcoholic for 30 years. He used to consume 2 times per week. A lost binge of alcohol 2 months ago. He is a chronic smoker for 40 years. He used to smoke off pack per day. His pack years is 20. Family history: there is no significant family history.
Sorry to disturb you, Indra Gandhi. Can you just go to the slide presentation mode, slideshow?
Make it as a slideshow. No?
Okay, sir.
So you completed your history. Yeah.
Yes, it's not going. Yes, sir.
Yeah, it will come.
Yes.
So you completed your history presentation. So what are the, can you summarize whatever you presented as a history?
Okay, sir. A 65 years old male, smoker, alcoholic, and known hypertension and systemic coronary heart disease with mild LV dysfunction. Previous history of NaOH2 and history of RTA for 1 month ago, followed by history of right leg pain. And after RTA, patient was bedridden, sir. So we are probably dealing with cardiovascular assistance, sir.
So he is a hypertensive also. For how long you say?
He is 15 years, sir.
So 15-year hypertensive patient had a dyspnea and exertion of grade 2, which was before 1 month he had the dyspnea, and after RTA he is now bedridden, right?
Yes, sir.
So, and he had a coronary incident, probably acute coronary syndrome. How long back?
6 years ago, sir. History of dyspnea and exertion, for which he was evaluated and diagnosed as a CAD, sir.
So it's a CAD, and can you name it as acute coronary syndrome, or it is just a chronic stable angina? So what's the type of incident occurred that time?
Probably chronic stable angina, sir, because patient doesn't give a history of hospitalization, sir. And only is.
Yeah,
Yes,
we can clearly say that he had a NVHA dyspnea and exertion, which is an angina equivalent, which increased in frequency, and he went to hospital for that.
Yes, sir. Yes, sir.
Increased, it might be either unstable angina or NSTEMI, but definitely not a STEMI because there is no coronary intervention.
Yes, sir. Yes,
so
sir.
it's probably an unstable angina or an NSTEMI. He suffered some 8 years back, right?
6 years ago, sir.
And that time they did an echo. He had a low ejection fraction.
Yes, sir.
And, you said it's a mild LV dysfunction. Is it a mild or a moderate or severe?
It's moderate, sir. 38%, sir. 30 to 40% is moderate, sir.
So what kind of patient we are dealing with now?
We are dealing with CAD with LV dysfunction patient, sir.
He's an elderly patient, first of all. Yes,
elderly patient, a smoker and alcoholic, systemic hypertension and known CAD with moderate LV dysfunction case, sir, without symptom of congestive cardiac failure.
So there are high risk for major adverse cardiac event for him, even if he undergo minus. Correct?
Yes, sir.
Yeah. Okay. Go ahead with the examination, ma'am.
General examination.
I would, in the history, I would like to ask you, how do you do that NYHA classification?
Yeah.
Yeah.
Can you explain it, Indra Gandhi?
Yes, sir. There are 4 classes, ma'am. A patient able to do its normal day-to-day daily activities like climbing upstairs, walking down, climbing downstairs, or gardening, reaping. With this, we can calculate the METs, ma'am. If it is METs 4, now patient able to reaping and gardening.
Don't confuse it with METs. They are asking what is NVHA classification. There are 4 classifications. So, is precipitated by which activity the dyspnea is getting?
Ordinary physical activities, sir. Like patient with ordinary physical, a patient no symptom with ordinary physical activity. That symptoms like palpitation, angina, dyspnea.
He is having
dyspnea.
So it is grade 2. If even with the ordinary physical activity is developing dyspnea, means it is grade 3, correct?
Yes, sir.
So is it okay, ma'am, or you need some more explanation?
There is a slight limitation of physical activity, then we can consider it as grade 2, isn't it?
Yeah.
Yes, ma'am.
Right. No exertion. And we should have his angina grading. What was his the intensity of pain that time when he had that episode 6 years back?
He doesn't give a history of angina. He gives only history of dyspnea and exertion is less than when he is able to do extraordinary physical activity, is not able to do it, ma'am.
So dyspnea and exertion can be considered as an angina equivalent. Not always patient present with the chest pain like tightness. Typical angina symptoms may not be there. So this dyspnea and exertion is considered as an equivalent of angina. So we can grade this only by NHA, not by Canadian scale of angina. So I think this is okay if the patient is present with dyspnea rather than chest discomfort.
Chest discomfort. And in acute coronary syndrome, do you consider only STEMI as an acute coronary syndrome?
No, ma'am.
All
STEMI
come under?
it divides into STEMI, STEMI, and unstable angina, ma'am. The 3 components is there, ma'am.
Okay. In a patient who is coming with IHT, the majority of the whatever information you have to gather is at the level of history itself, isn't it?
Yes, ma'am.
Other information is what you're going to get from the from examination, and some more you'll get at the level of the investigation. So, one thing is you should not use terminology like NYHA grade and all in the history. It should be in the patient's own words. Okay.
Okay.
You have told about the other injuries. You have excluded other injuries due to the fall.
Yes, ma'am.
Any antecedent events to the fall before? Is there anything else that has triggered this fall? Would you like to know that?
Syncopal attack of pain. Because patient is elderly patient may fall.
Your patient is, what is the age of your patient?
65 years old, ma'am.
65, okay. If there was any giddiness, syncope,
yes,
ischemic attacks that has occurred before the fall, that is the history relevant to us or not?
It's relevant, ma'am.
Why?
Because is a known CAD patient. Giddiness may be due to hypoperfusion to the brain, also will produce syncopal attack.
So obviously, if there is something that is precedent to the injury, it means the risk stratification is going to be in a higher grade, isn't it?
Yes, ma'am.
Okay. And when you talk about elderly patients in personal history, another important thing we should know is regarding the patient's vision, his easy hearing, whether he has a supportive family, isn't it? Because all the we talk about HIP is basically the rehabilitation.
Okay.
And for that, all these and the post-operative delirium. So all we are talking about not only the IHT, we have to look into what is the surgery the patient is undergoing also, isn't it? Take consideration both these factors, all the relevant things should come in the history level. So if it is a patient who is like above 65, 70, 75, the more geriatric the patient, you have to look into all the components which will tell how frail the patient is. The frailty. Look at all those things which will tell you how fast you can rehabilitate him, what will be the incidence of delirium post-op. All that should come into the history itself. How many days of hospital admission did the patient need like 6 years back when he was diagnosed to have a coronary artery disease? What that time?
He was not hospitalized, ma'am. He was evaluated and echo was done. Based on the echo, they are given a treatment, ma'am. He is not giving history of hospitalization for dyspnea and exertion.
Were there any admissions after that?
No, ma'am. No history, ma'am.
So after his treatment, what is his now? What is the present status of his meds before injury?
Before injury, he is able to do his daily routine activities, ma'am, without discomfort. On regular treatment.
Can you say it in terms of meds?
More than 4 meds.
What do you mean by that?
He is able to climb 2 flight of stairs.
Yeah, or walk 2 blocks at least. In our, you can say it's a flight of stairs is a good term. So, so what ma'am say is that one important thing is that we missed out is frailty. So what is the implication of frailty in post-op delirium is very important, that to elderly patient, that to for ortho surgery, because they are long-term bedridden. So how will you calculate frailty and what is a frailty?
Bead
Frailty
index.
is calculated in 3 steps. In step 1,
Basically says how independent the patient is and how he can take care of himself. Okay, so if he is a dependent on others for his even routine as like bathroom activities also, then the frailty risk is high and they are more prone for delirium in post-op. Especially GA causes more delirium in these patients. Even it's associated with regional also, but it has a important implication in post-operative morbidity and mortality, especially in a patient with cardiac comorbidity also. So, ma'am, can we go ahead with general examination?
Yes, we'll go.
general examination. Patient was comfortable at rest, conscious, oriented, afebrile, no pallor, no cyanosis, no generalized lymphadenopathy, no clubbing, no pedal edema. Pedal edema present in the right leg, moderately built, undernourished, warm peripherals. Weight was 55 kgs and height 170 centimeters. BMI was 19.03 kilogram per meter square. No elevated GVP or carotid buoy is absent.
Okay.
First, vitals.
Please go to slideshow. You are showing it once again in the presentation. Go to the slideshow.
Pulse rate was 74 per minute, regular in rhythm, normal in volume, no specific character, no radio-radial or radio-femoral delay, equally felt in all peripheral pulses. BP was 150-90 millimeters of mercury in right upper limb in supine position and 144-86 millimeters of mercury in left upper limb in supine position. Respiratory rate was 16 per minute, abdominal thoracic type. Saturation was 98% on room air. Airway examination, mouth opening.
Sorry to interrupt. So in that examination, you said that there is a swelling in the right leg, right?
Yes.
There is a history of trauma to the left leg, right? So is that so? Please be careful while typing all these things. This is just minor mistakes, so it has a major impact, and it will give a bad impression about you to the examiner. Okay. Okay. So in general examination, so you are saying that patient is comfortable at he is in lying down position, but he is comfortable. It means that there is no dyspnea. So we don't expect a pulmonary edema. So respiratory rate is normal. So any other positive findings you got from general examination? So what are the important negative findings?
Afebrile, sir.
So afebrile, what did it mean?
Patient is now not having any active infections.
There is no sepsis. So bedridden, we have to look for any bed sores, underlying urinary tract infection, all those things. Okay. So so there is a only pedal edema, that is only positive sign, which is in the injured leg.
Yes, injured leg.
So it has nothing to do with the cardiac. If it is a cardiac disease causing edema, it should be bilateral. In a lying down patient, it will be more ascites rather than the edema. Correct?
Yes, sir.
Yeah. So you mentioned about carotid bruit. Why it is important in this patient?
If
cardiac is an elderly patient, atherosclerosis is more prone in this case. So common carotid artery is also
it's narrow.
It's get narrowed due to atherosclerosis process.
Carotid stenosis is most common association with all the coronary artery disease. But if the absence of carotid bruit doesn't rule out the carotid artery stenosis. If the stenosis is severe, if it's more than a 90%, you won't get any bruit. So, but it's always a good practice to look for the carotid and look for the bruit. Okay. So they won't tolerate much hypertension in this patient. And his BPs are little higher side. So it's not well controlled. Though heart rate is good control. So BPs on the little higher side. So, okay.
In the pulse, in the examination of pulse, have you missed anything? Do you think examination, the character of the vessel wall is important?
Yes, ma'am.
Yes, ma'am.
We are discussing about the an ischemic heart disease patient. How do you examine for the character of the vessel wall?
Vessel wall will be thickened in atherosclerotic patient. It feels like a cord.
How will you examine for the vessel wall?
By 3-finger technique, index finger and ring finger should occlude the artery, and we have to palpate with middle finger.
That is, we are going to roll the vessel over the bone, underlying bone, with the middle finger. And what is the importance of seeing that blood pressure in the right upper limb and left upper limb? Any specific you want to look at?
It's a cardiovascular system, so we have to look for any right upper limb pressure difference, because patient can move for other causes also, like vasculitis.
Dr. Kirubanand, I am not aware of this. Is there anything like?
They mean to say, like, since he is not that much elderly and he is a 65 and got a coronary artery disease at the younger age, relatively younger age, so there may be chances of vasculitis should be ruled out in these patients. And he is a smoker also, so so they measured in specifically Takayasu arteritis can occur in this age group. So it's very rare in Indian population, but still we have to look for that. So they looked bilateral BP.
Looked at the bilateral. Okay.
So go with the local examination and systemic examination. Airway, please.
Airway examination, mouth opening more than 3-finger width, thyromental distance of 8 centimeter, mallampati grading 2, dentition multiple must 2 plus present, neck movements adequate.
So what do you mean by neck movement adequate? So what are the movements you look for?
Flexion and extension.
Flexion at Atlanta occipital. Hello. Extension at Atlanta occipital joint and flexion at the cervical spine, sir.
So
for all
elderly and atherosclerosis, there may be restriction in the extension. So you always look for that elderly patients and that missed tooth. So it should be documented what other tooths missed or loose tooths. So if you miss any tooth, it should be documented and it should be handed over to the patient.
How do you check for extension?
Delicate sign, ma'am. We have to keep the index finger, right index finger over the chin and one more finger over the occipital tuberosity, ma'am. You have to ask the patient to extend. If the line is above, the index finger is above the angle of the above the occipital finger, then it shows adequate neck extension, ma'am.
The simple thing is you can ask the patient to look at the roof. So if he is able to look at the ceiling above that, then the extension is adequate. Here, what is the, you have not examined for slugs, no?
Yes, ma'am.
That is one thing. Those 6 points you should not miss in any case, okay?
Okay.
General physical examination, you have not told about the examination of the spine.
Separately, we are telling in the
CNS examination.
Had it?
Yes.
Okay.
Cardiovascular examination, inspection, chest wall shape and symmetry. Chest wall shape is normal and symmetrical. Trachea appears to be in midline. Apical impulse seen to be in the left 5th intercostal space, 1 centimeter medial to midclavicular line. No scars, pulsations, sinuses, dilated veins, or precordial bulge. Palpation, tracheal position was confirmed. Apical impulse felt at left 5th intercostal space, 1 centimeter medial to midclavicular line. No palpable heart sound or no thrill. No palpable P2, no parasternal heave. Percussion not done. Auscultation, first and second heart sound heard in mitral, pulmonary, aortic, and tricuspid areas. No murmur and no S3 gallop. Other system examination, respiratory system, bilateral normal vesicular blood sound present, no added sound. Abdominal examination, soft, no tenderness, no free fluid, no organomegaly, bowel sounds present. Central nervous system examination, higher functions normal, no focal neurological deficit. Spine and cranial examination normal. Local examination, left lower limb examined in supine position, no swelling or redness. Hip joint movements restricted due to pain, no distal neurovascular deficit. Other side was normal.
Okay. So going back to systemic examination, so in a cardiovascular examination, you mentioned that chest is symmetrical and normal. So what do you mean by that, and what are the conditions ruled out in this patient?
Pectus excavatum and carinatum, chest wall deformities.
So keeping in mind that patient is a smoker, so what do you expect in this patient?
Barrel-shaped chest for COPD, sir.
And truncal obesity in CAD patients.
Yes. So you ruled out both, and you say that apical impulse. What is the normal position of apical impulse by palpation?
Left to 15 intercostal space, half-inch medial to mid-clavicular line.
So what do you expect in this patient? So patient is, you said already there is
it will be shifted laterally.
Yeah,
dilated cardiomyopathy would have occurred, sir.
So you expect there is no cardiomegaly in this patient, right?
Yes, sir.
So what is palpable P2? And there is no parasternal heavy you mentioned. What do you rule out by this?
Pulmonary hypertension
Why do you
cause palpable
in this patient? So he is an elderly 65 years old male.
So chronic smoker.
Yeah.
That's right.
Okay, and he is a bedridden. So for 1 month. So there may be chances of pulmonary embolism, and there can be chronic pulmonary thromboembolic events, so which may lead to RV failure. So that is ruled out by this examination. Okay. So another, can you go to the next slide? So S1, S2 heard in all area. So you have to mention which sound is louder in which area. So, okay. So S2 is loud in aortic and
pulmonary area.
And that characters you should mention. So why is S3 gallop important, and you mentioned about that?
S3 gallop will be present in left ventricular failure.
So can you say
rule out
pathophysiology of S3 gallop?
Ventricular.
Yeah.
Ventricular vibration Vinton produces S3 gallop.
I expect you to answer just like that. So basically, the S3 gallop occurs because as the ventricle become very stiff, the left ventricle, when the coronary supply is affected, the first thing, it's not the systolic function is affected, it's the diastolic function which is affected. So ventricles become stiff like a plastic bag. So once the mitral valve opens, blood just gushes in, but the ventricle is not dilating. It just go and hit the wall and turn back. So it creates some kind of mumbling sound. So that is heard as S3 gallop. So since S1, S2 and S3 comes, it's kind of, it gives sounds like a gallop. So it is called S3 gallop. So if it is there, then associated with JVP elevation and bilateral auscultation, there is a rails, then the patient is definitely in failure. So it is a contraindication for any active elective intervention in this patient, right?
Yes, sir.
So you said it's a pulse palpation, it is a regular. So what are the things you ruled out in this patient?
Atrial fibrillation.
So you don't say it's a atrial fibrillation. So it's a regular. Yeah. So you say that it's probably a sinus rhythm.
Yes, sir.
So mostly the sinus rhythm used to be regular, and any SVT also can be regular, but the rate will be very higher.
Okay.
So since this patient is also elderly, do you expect any other rhythm abnormalities in this patient? What is sixth sinus syndrome?
Bradycardia, sir.
So
SA no dysfunction.
That condition is also ruled out. Okay. Okay. So can you one of you summarize what are the positive and important negative findings from your history and examination?
65 years old male patient, a non-smoker and CAD without signs and symptoms of heart failure, not on acute chest pain. There is a known systemic hypertension on regular treatment, presented with a left hip pain following RTA. Previously, NIHA class 2 breathlessness. Following RTA was bedridden. It's probably a neglected avascular necrosis of femur head, planned for elective total hip replacement, sir.
So you are going to handle a elderly patient who is a smoker and a coronary artery disease patient and a hypertensive, long-term hypertensive, probably controlled, but now the BP is not well controlled, whose functional status is unknown, coming for a elevated risk surgery, correct?
Yes, sir.
So since basically we are dealing with the coronary artery disease, we like to discuss about the disease further. So let me share a few questions and try to answer those questions.
Kirubanand, before that,
yes, sir.
Sorry for interruption. Now, to point out to the postgraduates regarding the clinical case presentation, what has been missed in this presentation, what they have done mistake is that, as Madam pointed out, they didn't mention about airway and spine in a routine way. Even though it is a cardiovascular system discussion, postgraduates are expected to present the airway and spine examination in the proper way as if in a protocol basis. And they didn't elaborate much over the functional capacity as slightly pointed out. And as you told, the swelling, the change in the right leg and the left leg confusion. So those things has to be taken very carefully by all postgraduates, because there are a lot of postgraduates who are watching, all exam going PGs. So they have to be very careful in that. And one more thing which we have to get ready always is that getting ready for the question why. Whenever you put up some statements, the next question is from the examiner will be why. So you should have some answers for that question, like why you are measuring BP there, why you are measuring pulse there. So that type of questions are routine questions. So all postgraduates should be ready for such questions. And today we have got answers for all the questions. Yes, but you can start with your session on preoperative evaluation regarding this patient who is with the avascular necrosis, avascular necrosis of femur head for total hip replacement.
So what are all will you examine during spine examination? You didn't tell us your spine examination, no?
Is there any kyphosis or scoliosis?
Okay.
In inspection?
So we are going to be giving spinal at the level of lumbar. What will you like to see in this area? Whether the spine is palpable, whether the spinal spaces are okay. In a geriatric patient, what happens? There can be
ankylosing spondylitis.
Yeah, that you have said about in the airway examination. You said okay. Yeah, what about the infection at the site? Absolute concentration.
Yes, ma'am. It's a contraindication. Yes,
In geriatric patients, there can be supraspinous and interspinous ligaments calcification. Would you like to have a look at it? Is there edema? Like previously mentioned, if the patient had been chronically bedridden, then you should have a look at the edema and any source, bed source and those things present.
Okay.
Yeah.
Shall I go ahead with the discussion, sir?
Yeah.
Tejas, can you explain what is the blood supply of the heart and various factors determining myocardial oxygen supply and demand?
Blood supply of heart is by right coronary and left coronary artery, sir. Right coronary artery supplies right atrium, right ventricle, SI node around 55% and AV node. And left main coronary artery is divided into left circumflex coronary artery and left anterior descending coronary artery. Left anterior descending coronary artery supplies left ventricular anterior wall and anterior 2/3 of interventricular septum and LV apex and right anterior aspect of right ventricle. And left circumflex coronary artery supplies right atrium, left atrium, AV node, sir.
Okay. So, in order to clearly explain the coronary anatomy, so as the left main coronary artery comes out of the aorta, it divides into LAD, left anterior descending artery and left circumflex artery. So left anterior descending artery gives rise to diagonal branches which supply the anterior wall, which already you said, and the septal branches which penetrate to the septum and supply the anterior 2/3 of the interventricular septum. So the circumflex artery continues into the AV groove and comes in the posterior part, and it supplies the lateral wall of the left ventricle, and also anterolateral and infralateral part of the left ventricle also. Sometimes if it is a left dominant, it will continue as a PDA in the posterior interventricular groove. While right coronary artery arises from the aorta and grows in the travel in the AV groove, it supplies the acute ventricular branches, acute marginal branches, which supply the free wall of the right ventricle. And if right circulation is the dominant, it continues in the AV groove and continues as a PDR, posterior descending artery in the interventricular groove, thus supplying the posterior 1/3 of the interventricular septum. So the branches of circumflex arteries, important branches are the obtuse marginal. And as you said, SA node receives 50% supply from the RCA and 50 from the circumflex artery. So in any patient with RCA occlusion, they may present with sinus bradycardia instead of acute chest pain also. So, okay. So this is what you already said. So just this is the echocardiographic view. Because when we go for we view the echo, we should know which valve is affected and so which vessel is affected. So this is the transthoracic view, 4-chamber, 2-chamber, long axis, base and mid and apical short axis views are given here. So we can clearly see that this is the anterolateral valve, which is supplied by anterolateral circumflex artery, while the anterior and anteroseptal valve of the LV is supplied by the LAD tertiary. While inferior part of the septum or inferior wall, both are supplied by inferior part of the septum and inferior wall is supplied by the right coronary artery. This can be clearly explained in the short axis views. So this is the anterior wall, this is the inferior wall, this is the septum, this is the lateral wall. So this part is contributed by the LAD predominantly, and the inferior part is supplied mainly by the right coronary artery. Okay, while the lateral part predominantly by the circumflex artery, while right ventricle is free wall is supplied by right coronary artery. I hope it explains. When you see next time, if you see the regional wall motion abnormality, you should be able to tell which vessel is occluded. Okay, so that it is easy for us to monitor which lead to be monitored intraoperatively to look for any acute MA in perioperative period. So to give few more idea about the coronary vessels, there are 3 types of vessels. One is the conductant vessels, resistance vessels, and the veins. So we can see whatever coronary intervention are done only to the epicardial vessel. These are the conductance vessels. So in case there is a stenosis in these vessels, so and accidentally if we dilate all the vessels, so what happens is that there is a ischemic region here which is already excessively dilated. When you dilate other constricted vessels by arterial and arteriolar dilators such as dipyramidinol, so the blood supply predominantly goes to here and the blood gets stilled from here. This is called coronary still, which has a very important application in the perioperative management, which we'll discuss later. So can you explain the various determinants of O2 supply and O2 demand?
Oxygen supply is by arterial oxygen content, sir. And it predominantly involves hemoglobin and the coronary blood flow, sir. And oxygen demands is predominantly by contractile state of myocardium and heart rate and wall tension, sir.
Okay, so you have written terms like afterload and preload. May I know what is that?
Preload is the amount of blood that is present in the left ventricle at the end of a diastole, sir.
So,
afterload is
excuse me. If preload is too much, what happens to the subendocardial blood supply? It gets compromised. So preload should not be high. At the same time, it should not be too low. So if it is too low, what happens?
Output will be reduced. Cardiac output will be reduced.
So what is this afterload?
It's a tension or aortic resistance again, which left ventricle has to contract, sir.
So determines the force of contraction of the LV. In turn, it determines the oxygen demand, energy expenditure needed for the left ventricle. So you will target either to keep the afterload high or low in these patients.
Low.
So
both has to be maintained within the 20% of the baseline, sir.
Yeah. Okay. So you mentioned about heart rate. So how it determine the O2 demand in a cardiac patient or any other patients?
Increase in heart rate will lead to decreased length of diastole, sir. Thereby it decreases the coronary perfusion pressure.
So you mean so how in which phase of cardiac cycle blood supply reaches the myocardium most?
Diastole, sir.
So why not in the systole?
Because epicardial coronary also will contract during systole, sir.
Yeah, that penetrating vessels
will get constricted
the myocardium during systole. So the blood won't go from epicardial vessel to the myocardium. So blood won't reach the myocardium during systole, while in diastole blood reaches. So okay, so you mean so you will maintain a heart rate at a lower rate. So what is the strategy to keep the heart rate under control?
Avoiding the factors which increases heart rate like
pain,
pain,
anemia,
light plane of anesthesia, anemia, hypovolemia.
okay. So you mentioned here O2 supply, O2 content of the arterial blood. So what are the factors determine O2 content of arterial blood?
hemoglobin, PaO2,
Okay.
and
Cardiac output.
SaO2, cardiac outputs.
So any other substance can reduce the O2 content of the arterial blood? Like any inhibitors? What is oxygen dissociation curve?
Hypothermia, alkalosis,
Yeah. So this
methemoglobinemia.
so,
All these factors decreases the oxygen extraction.
ODC curve to left or right?
Left, sir.
So if it must shift more to left means, so what will happen?
Increase the oxygen affinity, decrease the oxygen supply to the tissue.
So you mentioned about coronary blood flow, O2 supply. So what are the factors determine coronary blood flow?
Coronary blood flow is defined by aortic end diastolic volume minus left ventricular end diastolic pressure. Sir. So if there is any increase,
you mean to say coronary blood flow is determined by coronary
perfusion pressure. Yes, sir.
So the formula is aortic diastolic pressure minus left
ventricular end diastolic pressure.
So if your preload rises, left ventricular end diastolic pressure rises, so reduces the coronary perfusion. If your afterload or aortic diastolic pressure reduces very low, once again your coronary perfusion pressure will decrease. Afterload should not be reduced too low.
Yes, sir.
Okay. So this is like in a pictorial representation of whatever we discussed now. So important disease which affect the coronary blood flow is the atherosclerosis. Can you say the risk factors of coronary artery disease and sequelae of the disease?
Risk factors is divided into modifiable and non-modifiable risk factors. Sir. Modifiable risk factors like diabetic, hypertensive, sedentary life, obesity, smoking, and familial history.
Okay.
Homocystinemia.
Okay.
Non-modifiable factors like age, gender, genetics.
So how does this atherosclerosis affect the coronary blood supply and lead to ischemia or infarction?
Because of these risk factors, it leads to endothelial injury in the blood vessels. It leads to activation of platelets, macrophages, and diffusion of plasma proteins into the tunica intima. That way, it causes macrophages converted into foam cells, and platelet will causes myoepithelial cells proliferation and LDL oxidation. That way, it causes atherosclerotic plaques. In chronic stable angina, this occlusion is chronic narrowing of coronary arteries. Whereas in acute coronary syndrome, this plaque is more vulnerable plaque, which leads to erosion or rupture or fissure. It leads to activation of platelets that gets occluded and that gets attached to the ruptured atherosclerosis plaque. Thereby, it causes complete occlusion or a partial occlusion. Sir. If it is a complete occlusion, it leads to transmural edema, that is STEMI. If it is partial occlusion, can lead to unstable angina or in-STEMI.
Okay, so so that is the reason. So if a patient with a STEMI, it's always needs a coronary intervention like PCI or ballooning or stenting or CABG. But in case of unstable angina where only the partial occlusion, this thrombus can dissolve with drugs alone, or it can be stabilized with medications alone. So if it's a significant stenosis, then they can go for coronary intervention. So what about this severe fixed coronary obstruction, when it becomes significant and when it should be addressed and what it causes?
And there is more than 17%. There is more than 70% coronary artery occlusion. It shows a significance.
Yeah. So
associated with chest pain, we have to.
Yeah. Okay. So if it is more than 70 to 80%, it reduces the flow. So yes, even at exercise, mild exertion, they will start getting pain. So 50% causes hemodynamically important reduction in blood flow. Correct?
Yes, sir.
So can you say what is the reason for ST elevation MI and what is the reason for NST MI?
It's mainly due to infarction. Full thickness in ischemia leads to STEMI, sir.
Yes, this is transmural myocardial infarction. Yeah. So this partial occlusion leads to subendocardial ischemia.
Ischemia. Yes, sir.
Generally, the blood flow distribution ratio to the myocardium is 10. It's about 10 times more to the epicardium, while 10 times less to the subendocardium. So when the blood flow starts reducing, it is the subendocardium which goes for ischemia and infarction first, comparing to the epicardium. So that's why, which is the most common infarction or ischemia we come in across in the perioperative period.
Subendocardial ischemia, sir.
Pardon?
Subendocardial ischemia.
Yeah, subendocardial ischemia. So this can be managed medically. So that doesn't need any active intervention like surgery or coronary intervention. So by controlling the heart rate, controlling the oxygen demand, means increasing the oxygen supply, so we can manage this situation. So this is the most common perioperative ischemia or infarction we come across. So that is a reason they said optimization medically is important rather than going for a PCA or CABG. Okay.
Yes, sir.
Yeah. So if the coronary artery disease proceeds further, what are the complications you expect and what are the complications present in your current patient?
So myocardial ischemia, acute coronary syndrome can explain. Then it leads to arrhythmias, pericarditis or pericardial effusion, or mitral regurgitation due to papillary muscle rupture, or can be a ventricular septal rupture, or a free wall of left ventricle get rupture, leads to cardiac tamponade, or patient go for LV dysfunction, or leads to cardiac mural thrombus or stroke, or patient can go for ischemic cardiomyopathy and heart failure and sudden cardiac death, sir.
So what is there any complication due to CAD in your patient?
No, sir. Actually, patient does.
Yeah, ejection fraction is low. So NVHA class 2 you said. So
Yes,
now functional capacity we don't know. So probably what might be there in this patient?
LV dysfunction is
yeah. So it is ischemic.
Yes, sir.
So ejection fraction is reduced due to ischemia or infarction, we don't know. So the patient might have a ischemic cardiomyopathy and mitral regurgitation status, we don't know. So we have to look into echo, correct?
Yes, sir.
So since you know your patient now, so what are your goal in a preoperative evaluation in patients with ischemic heart disease?
Since the patient is known CAD, sir, I want to go for function severity of the disease, sir, and functional limitation, and the patient on taking a tablets and prior investigation I want to look into, sir. Whether this patient need any preoperative specialized testing or consultation needed or not, and any risk factors which can be reduced preoperatively for this patient, I have to look into for that, and I have to reduce it, sir.
So you know that this patient is ischemic heart disease. So how severe is the ischemic heart disease in this patient?
It's not patient is not in failure.
Yeah.
Normal sinus rhythm.
Yeah.
It's now bedridden, so we cannot assess the medicine.
So it is not a very severe disease, but manageable. Yes, and so we need further additional
evaluation
to be done. So which we will discuss in the investigations part. So we will manage accordingly to reduce the perioperative morbidity in this patient. Okay.
Okay.
So what are the signs and symptoms of a coronary artery disease and how you grade the severity of the symptoms?
Patient usually have angina, sir.
Okay.
So and dyspnea. Angina classification is based on Canadian Cardiovascular Society, sir.
Patient. What is angina? Explain angina.
Angina is retrosternal discomfort or a pain or a band-like sensation or squeezing sensation which lasts for 5 to 15 minutes, usually radiating to C8 to T4 dermatom below the angle of mandible above the epigastric region, and usually aggravated on physical exertion, cold weather or emotional stress, usually relieved by rest or nitrate, sir.
Okay. So what is this Canadian scale?
On Canadian, it consists of 4 classes. Class 1, patient doesn't have any angina on ordinary physical activity, have angina on ordinary physical activity, angina less than ordinary physical activity, angina at rest, sir. So
a patient with angina of scale 2 for the past 6 months. So last 1 month he had the angina scale of 3 and it increased to 4. So what it implies to you?
The severity of coronary artery stenosis is increasing, sir, from 2 to 3. 3 significant coronary artery stenosis, sir, whereas class 2.
What is the patient is having now? Is it can be consider it as acute coronary syndrome? Yes, it
Patient can be
yeah, it's a rapid progression from one class to another within a very short period. Then it is an indication that patient is going for acute coronary syndrome, and it should be managed accordingly. Okay.
Yes, sir.
Yeah. So what is dyspnea can, yes, we already explained dyspnea can be an angina equivalent. So it can be a feature of heart failure in this patient. So what are the grades? And I think we already explained about that, so we can skip this. So these are the various diagnostic criteria for heart failure, major and minor. So as our patient is a bedridden, we can't assess the functional status. So if a patient coming who is active, so how will you assess the functional status of the patient, and how do you want to risk stratify this patient? Because explaining the perioperative expected morbidity and mortality of the patient is very important, and taking a consent is very important. So how will you assess and risk stratify this patient?
For functional status of patient, we can ask for metabolic equivalence.
Okay.
Then Duke activity specific index questionnaire, which consists of 12 questions. It gives a points, but based on the points we can convert into METs. If the functional capacity of METs is more than 4, patient can have a VO2 maximum 20 ml per kg per minute, sir. So patient can proceed for the surgery. If it is less than 4 METs, we can proceed for the further evaluation of the cardiac disease, sir.
So,
the patient,
yeah, existed. So there are so many other investigations we can do without asking these questions. So why are specifically emphasizing on the functional assessment? There are cardiac MRI available. You can do coronary angiogram, and we come to know which are the vessels not flowing. So why we are much more bothered about the functional assessment rather than investigations? And many guidelines give emphasis on the functional assessment. Why is it so?
for assessing the patient, that patient able to tolerate the stress of the surgery, sir.
Yes.
For that, we have to indirectly assessing the patient cardiac reserve, sir.
Yes. What is the allowable heart rate? Means maximum heart rate a patient can achieve. So how it is calculated? Any idea?
220 minus age of the patient.
180 target is 180 per minute, sir. In exercise.
Subasri said it's 220 minus age of the patient. So if the patient is able to achieve this heart rate without any coronary events, then it means that patient can undergo any major stress without any coronary problems. Okay, so the risk of perioperative MACE is very less in this patient. So that is the reason we are much more bothered about the functional assessment. So since your patient is bedridden, how will you assess the functional status of this patient? So is there any other alternative strategy?
Pharmacological stress test can be done, sir. Pharmacological stress echo can be done, or stress MRI can be done.
Yeah. How do you do that? Any idea used?
Bruce protocol can be followed for stress echocardiogram, sir.
Yeah, but
using Dept.
Treadmill based. So what is the drug used for stress echocardiography, in a pharmacological stress echocardiography?
Dobutamine, adenosine dipyridamole can be used, sir.
So dobutamine is the most commonly used. So, a few words about the dobutamine stress test, because few anesthetists might ask. So we will start at 5 mics per kg per minute of dobutamine, and every 3 minutes we will increase the dose up to 10, 12, 15, 20 mics per kg per minute. So till we reach the heart rate of the target heart rate, like 85% of the maximum heart rate for that patient's age. So if you are not able to achieve that, we can use atropine also. So we can follow the ECG and imaging like echocardiography. So we can document how the heart is behaving. Is there any new onset regional wall motion abnormality? And we can get an idea how much of myocardium is under ischemic stress if the patient undergo surgery. Okay. Yeah. So this is your METs and Duke activity specific index questionnaire. So I think everybody knows this. We can skip this. So what is this? How will you risk stratify this patient? So you have to take a consent and you have to tell the patient you have this much percentage of chance of heart failure or bad outcome out of the surgery. So how will you say?
The revised Goldman cardiac risk index, sir. There are risk cardiac indexes is there, sir.
Yeah. So this revised is Lee's cardiac index, right?
Yes, sir. Revised Lee cardiac index.
So what are the parameters checked in this?
Patient, the type of surgery, sir. Whether the patient is having ischemic heart disease, history of congestive cardiac failure, or cerebrovascular accident, or diabetic mellitus, or requiring insulin, or serum creatinine more than 2 milligram per deciliter. There are 6 parameters. Each one has gives 1 point, sir.
Okay. So when you say it is a low risk, intermediate risk, high risk, so what is the guideline now? How will you divide them?
It's based on AHA guidelines. If a patient is having 0 or 1 risk factors, comes under low risk, less than 1%. If it is 2 or more clinical risk factor, the patient is considered as elevated risk, more than 1%, sir.
Okay. The term of moderate and high risk are abolished now. Only elevated risk is there. Okay. So is there any other methods to risk stratify? Only RCRI is available, or any other methods available?
All
Any
the criteria like Goldman cardiac index and
that got revised into Lee's cardiac index. So anything else?
NQSIP, sir, National Quality Surgical Improving Programming for Risk Calculator, sir, and MICA, myocardial infarction and cardiac arrest surgical risk calculator, sir.
Okay, these are online calculators. What is the specialty of NSQIP questionnaire is that it also includes ASA grading. Okay,
Yes,
so you know there is an update of ASA grading.
Yes,
in recently 2020 they published a new grading system for ASA. So can you say which grade our patient comes in? It's a ASA, which grade? ASA 1, 2, 3, 4, 5, 6. So which is our patient can be classified as?
Our case is under ASA 3, sir. It's
so okay.
Because patient is having moderate LV dysfunction, sir.
So yeah, that's a coronary artery disease
with moderate LV.
So if it is with a severe LV dysfunction, he will be grade 4, or in acute coronary syndrome, he will be ASA 4 grade. Okay. So I think this guideline madam will discuss later, I hope so. So see these steps, since it is not an emergency, we are going for active. There is no active cardiac conditions also. So we will risk stratify this patient. So it's an elevated risk patient, and we have to assess the functional capacity, but we are not able to assess the functional capacity. So you said we will go for dopamine stress test. Okay.
Yes,
okay. So this is another grading system which says instead of that functional capacity, we can use biomarkers also. So this BNP and N-terminal pro-BNP has also important predictive role, especially in a cardiac patient. So values you have to look into. If it is more than 300 NT pro-BNP, then it indicates there is a high risk of adverse cardiac outcome in a patient. Okay. So since our patient is also a heart failure patient, can you say what is the recent update in stages of heart failure and elaborate management strategies for patients in each stage?
There are four stages. Stage A, the patient who are high risk for heart failure, but without structural heart disease or symptom of heart failure. A patient who are under risk factors comes under this, and the treatment is you have to reduce the risk factors like reduction of weight, cessation of smoking, reduce the salt intake, and controlled treatment for hypertension. In stage B, the patient was having structural heart disease but without symptom of heart failure, that is patient with CAD with LV dysfunction or asymptomatic heart disease. Treatment is it concludes of a patient stage A treatment plus we have to start AC inhibitors or beta blockers are appropriate for the patient. And stage C, the patient with structural heart disease with prior or a current symptom of heart failure, that is CAD with LV dysfunction with features of heart failures like breathlessness, exertional dyspnea, fatigue. Treatment is you have to reduce risk factors, and you have to start AZ and beta blockers plus diuretics and digoxin we have to start. And stage D is a refractory heart failure requiring specialized intervention that includes it includes a whole 3-stage management, plus patient needs a continuous IV inotrope supports or a mechanical assisted device or cardiac transplantation or hospice care.
So, okay. So you mean to say that stage D patients can be considered as having active cardiac symptoms and they are not a candidate for any elective
procedures.
So stage C we can optimize, and stage B definitely we can optimize and take for elective surgery. So which stage is in our patient is in now?
B, sir, structural heart disease without symptoms of heart failure.
So you will definitely encourage him to quit smoking, and you will continue the drugs, right?
Yes, yes, sir.
So in this patient, what are the investigations you will order to reduce the perioperative adverse outcomes?
I will look for hemoglobin, sir.
No, first you have to say the investigations which will support your diagnosis, like X-ray, hip or whatever, and then for the cardiac situation. Okay. So first go in that order.
I want to confirm my diagnosis by taking X-ray, left hip, AP, and lateral view, sir. Then I go for a cardiac evaluation, like ECG. Apart from routine investigation, I go for a ECG and echocardiogram, sir, and X-ray.
Okay, so ECG, what do you expect in this patient?
Since the patient is having more LV dysfunction, no CAD, I will look for any old MI features, sir, like Q wave and leads. In if it is a right coronary artery stenosis or inferior wall lemma, I look for a Q wave in lead 2-3 AVF, sir.
Okay, so lead 2-3 AVF, which valve it indicate? Like where do you expect regional valve motion abnormality in the heart when there is a abnormality in these leads?
Right coronary artery, it indicates it's predominantly in the inferior wall, sir.
Inferior wall or infralateral. So okay. So for lateral or anterolateral and high anterolateral, which are the leads you will look for?
One AVL, V5, V6.
Yes. Okay. So for anteroseptal valve, which are the leads you will look into?
V1, V2, sir.
Yeah, V1 is more of a right sider. So V2, V3 can
V3, V4.
V3, V4 to V4. Okay. So ECG you read, and you will look for the rhythm also. What do you expect if there is a scar in the myocardium? So what do you expect?
Q wave, sir.
Yeah.
ECG pathological Q wave will be seen.
Any ectopics can be there. Ventricular ectopics, like called VPCs, can be there. Okay. So what are the types of VPCs you know?
Monomorphic and polymorphic.
Yes, you can loud. Subasri, you can talk loud. We are not able to hear you.
Monomorphic and polymorphic.
Yeah, okay. So if there is a monomorphic PVC, so what did it indicate?
Non-cyst. It can be VT, sir.
No, this PVCs can go to the scar tissue. So it's a scar. So it's not going to affect our outcome anyway. So if it is a polymorphic VPC, then are you concerned?
Yes, sir.
Yes. So what and all you will look into if there is a polymorphic VPCs?
Electrolytes abnormality should be that, sir.
So what are the electrolytes abnormality you expect?
Potassium.
Yeah, and important?
Calcium.
No.
Magnesium.
Yeah, magnesium. So it's potassium and magnesium. So magnesium is very important for electrolyte conductivity. So if it is always associated with hypokalemia also, so both electrolytes are abnormal, we should correct it. So if there is any VPCs, you will go for serum electrolyte evaluations also. Okay. Okay. So what are the other investigations you will go for?
Echocardiogram, sir.
So what are things you will expect from echo?
I want to look for regional valve motion abnormality and ejection fraction, sir.
So, okay. Yeah. So do you look for any other thing? You said there is a systolic dysfunction. What is mean by ejection fraction? So how will you grade the systolic function? You said mild, moderate, severe already. How will you grade this severity?
If the ejection fraction is less than 25%, it is severe.
No. What is the normal ejection fraction?
50 to 60% is normal. Yes, sir.
So what is mild LV dysfunction?
40 to 50.
Yeah, 40 is mild, 30 to 40 is moderate, less than 30 is
severe, sir.
Low EF itself is a independent predictor of worse outcome in the perioperative period. Okay, so especially patient with EF less than 30. Okay, so there is a systolic dysfunction. Do you expect, what are the two kinds of heart failure? Do you know?
As a diastolic heart failure, systolic heart failure, or high output cardiac failure, or low output cardiac failure, right heart failure or left heart failure, sir.
No, these are old terminologies. Something new have come and they abolished all the old terminologies. There are only two heart failures.
Reserved heart failure,
Yeah.
EF reserved and low EF.
Heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. So this heart failure with preserved ejection fraction is nothing but the diastolic dysfunction. So in a patient with ischemic heart disease, diastolic dysfunctions also occur because the diastole is an energy dependent process. It's not a passive process, okay? Like a rubber band, it won't recoil. So it needs an ATPs to recoil myocardium. So if there is ischemia, diastole also get affected. So you expect diastolic dysfunction in these patients. So what are the grades of diastolic dysfunctions, you know?
Grade 1, grade 2, grade 3, sir.
Yeah, yes, grade 3. Grade 3 is restrictive. Yeah. So more the grade, severe the congestive. Yeah. Okay. So, okay, good. So since there is a low ejection fraction, you said something about mural thrombi. You should look for that in the akinetic region also. Okay. So if the patient is having mural thrombi, this patient should be in a adequate anticoagulation, including warfarin. So because there is a chance of embolia is very high in these patients. So any other investigations you will ask for?
Chest X-ray, sir.
Yeah. So what are the parameters you will look into?
Look for a cardiomegaly and pulmonary venous congestion, sir. So
cardiomegaly, how will you look for a cardiomegaly?
Measuring maximum transverse diameter of the dome of the diaphragm and the maximum divided by maximum transverse diameter of the cardiac silhouette. It should be less than 50%, sir. If it is more than 50%, we consider as cardiomegaly, sir.
The numerator is maximum diameter of the cardiac silhouette. Denominator is the maximum diameter. Yeah. So if it is more, if 50 is a normal, if it is 70 under, there is definitely a cardiomegaly is there. Okay. So and also you will look for pulmonary congestion, you said. So yes, any terms related to the pulmonary congestion?
Yes, sir. Curly A, curly B, curly A, curly B lines, sir, and circulation of pulmonary veins towards the upper lobes, sir.
Distribution of pulmonary vasculature in the upper lobes. Okay. So, so with these things, you will come to know how bad and what is the cardiac reserve in these patients. So, for functional capacity, you already told dopamine stress echo. So, if it becomes positive and if the patient is having left main or any other significant stenosis, or there is a large area at risk of infarction, these patients should go for coronary intervention before coming for an elective surgery. Okay. So any other investigations you will do for sake of surgery?
If the patient is on dual antiplatelet drugs, I want to look for platelet BTCT.
Okay.
Platelet counts and BTCT, sir.
Okay. So any other thing? Do you expect blood loss in this patient?
Typing.
Hello?
Yes, sir. Femur fracture. Since it's a femur fracture, we can expect blood loss, sir.
So what investigation, what else you will do?
I want to look for RFT also, sir, since it's a low output cardiac.
Regarding blood, do you want to do grouping and
yes, sir.
As much keep blood ready?
Yes, sir. Blood grouping.
Yeah, okay. So why do you want to do RFT?
Since it's a low cardiac output status, so renal perfusion may be decreased. So look for the RFT, sir.
Okay. So RFT, what and all you look into?
Serum creatinine. We can in blood urea and serum creatinine can be seen, sir.
Okay. Okay. So this patient is also had a fracture. So there a renal shutdown would have occurred at the time and must be recovering or might be going worse. So we have to look at. So you mentioned as LFT. So is it necessary in this patient?
No, sir. Since the patient doesn't have congestive cardiac failure features, doesn't need LFT, sir.
So he had no history of liver disease also. So don't do unnecessary investigations. So LFT and all don't mention. So if you are mentioning something, you should be able to justify. Okay.
Okay, sir.
Okay. So patient must be on various medications. Can you explain few anti-anginal medications and how will you, whether you will continue intraoperatively or you will stop, which are the drugs you will stop, which are the drugs you will continue?
Patient can, now this patient is on tablet nitrates, tablet isosorbate dinitrate and atenolol 50 milligrams.
Okay.
So we'll ask them to continue the beta blocker till the day of surgery. As per AHA guidelines 1, we can continue the beta blockers till the surgery, sir, and also in the perioperative period we can continue, sir.
Okay.
Nitrates also we can continue, sir.
So what is the type of beta blocker you are using? So can I, is it a cardioselective or any other drugs?
Cardioselective drugs, sir.
So what are the drugs?
Metoprolol, atenolol, bisoprolol, acebutolol.
Okay. So is that only beta blockers or even labetalol, carvedilol, any other newer drugs available, alpha plus beta, much more better drugs? If the patient is asthmatic, so will you continue beta blockers, selective beta 1?
We can continue, sir. We can continue.
Yeah.
Continue, sir. Carvedilol is good, alpha and beta blocker.
Go for lesser selective beta blockers rather than going for B1 selective beta blockers.
Okay, sir.
So how the nitrates work?
It's predominantly venodilator, sir.
Okay.
It releases nitric oxide and produces vasodilatation, sir.
Okay.
It decreases the preload as well as afterload, sir.
Okay. So it doesn't cause dilatation of all vessels. So dipyridamole and hydroxyzine are not used for coronary dilatation because of this reason only. Okay. So thinking not used in the intraoperative period. So what about calcium channel blockers? You mentioned it. Should we use that?
For rate, in Prince metal angina, we can use for relieving pain, sir. Okay. Prince metal angina.
So in case where beta blockers are contraindicated, then you think of a calcium channel blocker. Otherwise, calcium channel blockers are not routinely used. Why it is not used for angina patients?
And it's a myocardial depression, sir.
It causes severe myocardial depression comparing to beta blockers. So if at all it have to be started, it have to be started in a titrated dose, and in intraoperative period should not be started just like that. Okay.
Okay, sir.
So any other newer drugs you know for rate control, which has a fewer side effects?
Ivabradine, sir.
Yeah, ivabradine. So what is the drug?
It's a funny channel sodium blocker, sir.
Okay, so it acts selectively on the SA nodes. So it's only affect the rhythm, rate. Acts only when the patient is in sinus rhythm. So it is found to be lesser side effect, no myocardial suppressant activity like beta blockers. So if the patient is not on any beta blockers, we can start intraoperatively, but the problem is that it's available in the oral format only. Okay. So it's given as 5 mg. It can given as 6th hourly 5 mg, or total dose should not be more than 20 mg per day. Okay.
Yes, sir.
Yeah. So I think, sir, shall I continue with the other questions?
Kiruba, shall we switch over to madam's this thing now?
Sure.
And we'll ask this antiplatelets and anticoagulants during the preparation of this patient for Femur.
Sure.
Sri Priya, madam, can you continue from here?
Yes, sir. That was a very exhaustive discussion of the pathophysiology of IHT and what all you can expect. So now I want you to concentrate on this patient and say, according to the AHA guidelines, what is it, how will you risk stratify this particular patient who is coming for arthroplasty surgery for this particular patient? The 7 steps, you have to go through the 7 steps.
Yes, sir.
And you people are seeming to lose energy. Your voice become low. Can you become?
First, we have to look for whether this is emergency surgery or elective surgery.
Yes, what is it? We have the surgery in front of you.
Yeah, it's elective total hip replacement surgery. It's elective surgery.
Yeah.
And then it is the patient doesn't have any active coronary diseases, ma'am.
Yes, okay, that is the step 2.
And then third, revised cardiac risk stratification used a revised cardiac risk index, ma'am. This patient is having more than one elevated risk, ma'am.
No, more than one. What are the risks in this patient?
Only ischemic heart disease, ma'am.
One is ischemic heart disease. You know that very well. Based on the serum creatinine, your risk will increase or no, isn't it?
Can be increased, ma'am.
Yeah, if his creatinine is 2, obviously it will come into the score.
Elevated risk.
When it goes greater than 1. Suppose it's normal, then it is a score of 1.
Yes, ma'am.
Are you able to hear?
Breaking. Yes, ma'am.
Am I audible?
Yes, ma'am. Audible.
So now we'll consider that his creatinine is less than 2. So TRI number of score is 1 and the risk is how much? Less than 1%.
1%.
No risk.
What is the next step?
We can proceed to
function assessment, ma'am.
If it is less than 1,
Less than 4.
If it is less than 1, we can proceed to surgery.
we can proceed for surgery. Suppose
If
it's greater than 2.
he comes under the elevated risk,
Yeah.
then we have to do a functional assessment. If the meds is more than 4, then we can proceed to surgery. If meds is less than 4,
So now I want only for our patient. You are very clear that it is more than 4.
Yes, ma'am. His meds is more than 4.
More than 4.
Can proceed to surgery.
Surgery. So whether his creatinine is less than 1 or more than 1, we can proceed.
We can proceed to.
What is the difference you will do in these two conditions? If it was less than 1 and more than 1, what is the difference in your management strategy that you will employ?
Continuation of
Basically, you're monitoring, you're going to step up, isn't
yes.
Acceptance for surgery is there, but you should explain the additional risk to the patient and step up your monitoring accordingly. Okay? So about the risk stratification of this particular patient. The other thing was a patient is a platelet patient is on what all drugs did you say?
Amlodipine, atenolol, isosorbate dinitrate, aspirin, clopidogrel, and atorvastatin.
So what all drugs will you continue for an elective surgery?
I will continue aspirin 75 milligram and antihypertensives. I will continue statin and I will stop clopidogrel 5 days before surgery.
Okay, how do you categorize a surgery? He is coming for a total hip replacement. How do you categorize surgeries?
Intermediate risk.
Intermediate
It comes
risk
under
surgery.
Not about the intermediate risk. So now in the recent guidelines, we have taken into consideration the surgical factor as well as patient characteristics and come to a specific number of less than 1% or more than 1%. How do you categorize surgeries as urgent, emergency?
If the patient's life or limb threatening, it will be considered as emergency surgery.
Yes.
We have
Should be taken up?
Less than
6 hours. Ideally, less than 1 hour. We can take up less than 6 hours.
Okay.
If it is an emergency surgery, we can do within from 6 hours to 24 hours.
Okay.
If it is an time sensitive surgery, we can wait up to 6 weeks. If it is an elective surgery, we can wait up to 1 year.
So in which category does this total hip replacement fall?
This is emergency surgery.
No, it is not it's not a life-threatening or limb-threatening thing. We still can take time to optimize. So we can put it in the category 3 that we have to undergo the patient.
Yes.
We don't need to wait for 1 year and more for doing the surgery.
Yes.
The only consideration for us is the patient is on clopidogrel, isn't it?
Yes, ma'am.
Clopidogrel. Now, all the decision you have to make is it, can we wait for how much time do you want to wait? For
5 days. 5 days.
5 days. So yeah. So you can wait for 5 days and take up the patient.
Yes,
so what continue? Atorvastatin, atenolol, amlodipine,
beta blocker,
aspirin. Yeah, I told you atenolol. What is the other drug is on? Nitrate.
nitrates.
So all these drugs you are going to continue in this patient, isn't it? Now, okay, we'll come to the intraoperative management. What are your anesthetic goals in this patient? That is this particular patient, that is a 65-year-old patient with IHD with moderate LV dysfunction.
The main goal is
drugs who is coming for hip replacement? What are your
The main anesthetic goal is maintenance of coronary, maintenance of myocardial oxygen supply demand balance.
Yes.
This is achieved by increasing the myocardial oxygen supply and reducing the demand.
So in terms of cardiac grid elements, how will you ensure that your oxygen supply and demand is properly managed? In terms of the cardiac grid elements. Basically, these are the 5 things you're going to manipulate, isn't it?
Optimal preload, optimal afterload, and
Heart rate should be under control.
How much?
60 to 80.
Okay. If the heart rate is less than 40, what happens?
Coronary blood flow, cardiac output will be reduced.
Yes, cardiac output is less, obviously, the coronary blood flow.
Perfusion also decreased.
Right. Next, so you talked about the
contractility.
Contractility, yeah.
Contractility should not be.
Should not increase the myocardial contractility.
Yeah, should be maintained. You do not want to depress it too much also.
Yes.
You either want to depress it too much because your output will come down, or you do not want to increase the contractility because that
it increases the oxygen demand also.
Oxygen demand. Okay. So you spoke about the rate, the contractility.
Preload, afterload.
And then pulmonary vascular resistance. How do you want to maintain it?
You should not increase pulmonary vascular resistance.
Yeah, do not want to increase. So what all causes an increase in pulmonary vascular?
Acidosis, hypoxia, hypercapnia,
nitric oxide.
Apnea and hypovolemia. All this may increase the pulmonary vascular resistance. So again, yeah, this oxygen supply and demand, we have already discussed it prior. When we come to hemoglobin, that is oxygen content is primarily determined hemoglobin content. What is the acceptable level of hemoglobin in this patient if you want to take up a surgery?
More than 10 grams.
More than 10 grams per deciliter.
What will be your transfusion trigger?
10 grams. If it is less than 10, you have to transfuse.
Okay, the recent evidence is that you can allow even up to 8%. But take into consideration all the other factors also, such as what is the setup in which you are working? What is the extent of post-operative monitoring? How much of a cardiology support will you get if there is an incident in the post-operative period? So based on that, according to guidelines, it is 8%. So in terms of cardiac grid elements, this is what we want. We want the patient to have the heart rate to be somewhere between 60 to 80 beats per minute. The rhythm should be sinus rhythm. Any tachycardia decreases output. If there is an alteration of rhythm, like if it is an atrial fibrillation, again, the cardiac output comes down. Contractility, maintain it. Preload, maintain it. SVR. In terms of SVR, what you didn't tell me about that? SVR, how the SVR?
Should not be too much. It should be maintained. Now should be too. You should not reduce to decrease or to increase. It should not done. It should maintain almost the baseline.
A mild decrease is favorable because that will increase the forward flow, isn't it?
Yes,
so is okay, but avoid excessive decrease.
Yes.
Because mean arterial pressure has to be maintained and the diastolic pressure has to be maintained. Okay, you got this in your mind clear? Preload, maintain it, and pulmonary vascular resistance, avoid an increase. So now we know any anxiety can cause an increase in heart rate and blood pressure. What are the measures you will take in this patient?
Voice is breaking.
Hello.
Hello.
Am I not audible?
Yes. Audible, ma'am.
What are the anxiolytic measures?
In the preoperative day, I will give alprazolam 0.25 mg,
which is one night.
Preoperative night, and in the morning, I will give injection midazolam for his weight of 2.5 mg IM.
Yeah, you're talking only about the pharmacological methods, isn't it?
Yes,
Anxiolysis than just using medicines. What else can you do?
Psychologically,
Patient.
Counsel
Explain.
the patient.
Huh?
Counsel the patient regarding.
Yeah, counsel regarding what?
Procedure, how we are going to, I mean.
procedure and surgery.
Talk to him. regarding
Yes,
what he can expect out of it. You can explain to him that you're going to be there monitoring because he is a high risk patient. He also knows he has a ischemic heart disease, and you can explain to him what he can expect during the conduct of anesthesia and immediately after that, and that he can call whenever he has a problem. All this helps to allay the anxiety. Most of the time, the anxiety is due to what? Patient may feel what will be the extent of pain, unknown environment inside the theater. So, proper discussion with the patient is more important in allaying anxiety than just depending on the anxiolytic medications. Okay, during your pre-anesthetic visit on the day prior to surgery, what will you do?
I'll get informed written high risk consent, and I'll
check for
explain about NPO.
How much time is the NPO order?
For clear liquid 2 hours and solid food 6 hours.
For heavy meals, it's 8 hours.
We mean the 8 hours.
Is this specifically important that 2 hours prior patient can take fluids? Is it especially important when you are dealing with geriatric population?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
In geriatric patient, the lower eosinophil sphincter tone will be reduced. So they are more prone for regurgitation.
Geriatric patients are prone to be chronically dehydrated, not a patient who's like 60, 65, but as you go more and more older patients, so then it is very important that the volume status there, euvolemic, before you're taking up the surgery.
Yes.
Okay, then what are the other orders you're going to give?
Whether they have carried out the pre-anesthetic checkout list, ma'am.
No, I'm asking you what is the things you're going to do on your pre-anesthetic visit on the day prior to surgery. One thing you told, you're going to instruct on the NPO order. Second thing is informed consent. Then
adequate blood reservation.
That is what we are going to do as our process. What is it you're going to instruct your patient?
Continue the medication. What are
Continue
the
all the medications.
Except
you're not planning to stop any. We have assumed Pidogrel has been stopped for 5 days. All the other medications he has to continue. And you're going to give your sedative pre-medication. What is the dose you will give?
Alprazolam 0.25 mg 1 HS.
Is it always necessary to give these anxiolytic medications?
If a patient is anxious, we should give.
And you're going to look at his cognition, his level of understanding. Very old geriatric patients, they do not need this sedative. It can be counterproductive also, isn't it? Patient has a respiratory depression. Okay, then what happens to the PVR? It increases. We don't want all this. So it has to be customized to the patient you are dealing with. So on the day of surgery, the patient will receive the patient in the preoperative holding area. You can proceed. How will you manage?
I will reassess the patient and I'll check vitals. In the meantime, I'll inside the OT theater, I'll check anesthetic workstation and get ready for emergency drugs and defibrillator.
Creation of the OT should happen in whatever the systematic thing you can tell for everyone. One specific format. What all will you check for?
Patient vitals.
You have that SOAP mnemonic, isn't it? SOAP me. Are you aware of that or not? You're going to check the suction, keep an alternate oxygen source. Huh?
Yes,
then you just can finish it in around 15 seconds, isn't it? All those things in a specific format. Remember that you have to keep suction. There should be an alternate source of oxygen. Airway equipment you're going to check. Pharmacy. What are the medicines you want to use for elective? No, even elective, emergency, whatever you're planning in case of you are keeping atropine, you're keeping vasopressors, inotropes, whatever you're planning for the patient. Are they all ready? MS, do you have all the monitors in place? And have you done your pre-anesthesia machine checkup?
Yes.
All this has to be done. Then
I'll secure 16 gauge IV cannula. If patient is more pain sensitive, I will apply Emla cream and then I'll put IV line.
If you're going ahead with the 16 gauge, then definitely you have to use local. But is it that you're going to go with the 16 gauge? Is an 18 gauge sufficient?
No, we are expecting blood loss.
If 16 gauge is enough, ma'am. If we need now, we can put sample.
Okay, fine. So depending on the extent, how much of blood loss you are expecting, anticipating in this patient, decide on whether you're going to take a 16 gauge or an 18 gauge line. What is the specific thing you're going to ensure is ready in the theatre for this patient, especially when we are talking about a heart disease patient? They can go for arrhythmias intra.
Monitors, echo machine.
Defibrillator. Defibrillator is checked and kept ready in the OT. What are the intraoperative monitoring you're going to employ in
ECG, pulse oximeter, and NABP before the procedure, and after the procedure, after if I am doing epidural, after that I will put central venous catheterization and intraarterial BP monitoring and
Temperature program.
Okay. So you are saying pulse oximeter, ECG, NIBP, temperature, right? And then what did you say? Arterial blood pressure and CVP. Any other monitors?
If it is GA, you can go for ETCO2 monitoring.
Can't you do that if the patient is spontaneously breathing?
we can
Do.
We can. So capnography monitoring can be done even in patients you're not giving GA. Then the other thing is urine. You want to monitor it.
Yes, ma'am. Urine output.
Urine. If the patient is catheterized, suppose it all depends on the duration of surgery. If the surgeon says, I'm going to finish it in 1.5 hours, do you need a catheter?
No.
Won't. Because every catheter that is inside, there's an additional chance of infection. So depending on the surgery and thing, for a THF, we can still ask that the patient be catheterized. So you told about the ECG monitoring. What type of ECG monitoring you want?
5-lead ECG monitoring with lead 2 and lead 5. V5.
Okay. Lead 2 and lead 5. Lead 2, you're going to monitor what? With
rhythm.
Rhythm. Okay.
And in lead 5, we'll monitor ischemic changes.
Fine. Where do you place the V5 electrode?
Anterior axillary line.
In which intercostal space?
6th intercostal space.
Pardon?
5th intercostal space in the
intercostal space. So yes, this is how we place the ECG electrodes. So we should know that based on our patient's basal ECG, you should have an idea of which coronary artery is involved in which you want to monitor, and accordingly you're going to place the ECG electrode. So if you think it is an LAD for him, okay, then we can go for V5. If we are adding, like we are monitoring V5 alone, we can detect how much percentage of ischemic episodes.
Lead 2 and V5, 80%.
Yeah. So with V5, approximately 70%. With along with that, you can detect 6% of this. With V5 alone, around 70% of episodes you can.
Okay.
With along, if you are adding lead to that, 86% of ischemic episodes. And along with that, if you can do a V4 monitoring,
90%.
100%. So to do a 3-lead monitoring, you will need to have 6 leads in your ECG machine. So what is your target blood pressure you want to maintain?
From baseline, 20% from the baseline.
Okay. That means for him, a mean arterial pressure of what? You said it was 150, 90, no?
90.
What is more important, systolic, diastolic, or a mean arterial?
For him, diastolic.
Mean arterial pressure is very important.
So yeah, for him, like mean arterial pressure is going to determine what is the organ perfusion.
Perfusion, yes.
That should be always about 70. Yeah, he's a chronic hypertensive also. If he has been in uncontrolled, then you may probably have to increase it because of the shift in autoregulation curve to the right. For him, as an IHT patient, also pay attention to the diastolic blood pressure. There should not be a fall in the diastolic blood pressure.
Okay.
What is the fluid of choice?
A balanced salt solution like RL.
Why not normal saline?
Lactate. Normal saline because hyperchloremic acidosis and it is
good. That is
hypotonic.
Not hypotonic. Then if you give answers like this, then we'll automatically go to the next question. What is so normal saline is the right answer. Normal lactate is the right answer. It's a balanced salt solution, and you prefer that. Okay. What are the different anesthetic techniques you can use for this surgery?
Combined spinal epidural, but low dose spinal and epidural.
I am asking you just first mention what all different techniques you can.
Sole epidural anesthetic. Combined spinal epidural, plain spinal, and epidural with the GA. Epidural general anesthesia with peripheral nerve block.
So these are the different techniques you can employ, isn't it? What is the advantage and disadvantage of central uraxial block over giving a general anesthesia?
Advantages are there will be no airway manipulation. So intubation and extubation, there will be no intubation or extubation stress response. And
first, you tell about the advantage of giving a central uraxial block, not the GA. First is the technique itself. What are the advantages?
Adequate pain relief.
Yes. Dense, intense pain relief.
Intense pain relief.
Decreases incidence of DVT.
Yes.
Early mobilization.
Early post-op pain relief also it provides.
Right.
Increases stress response. Properly blunts the stress response that is happening. It can cause a certain extent of coronary vasodilation also. These are the advantages of central uraxial block. And what are the advantages over giving a general anesthesia is what you said. You can avoid airway manipulation. Am I not audible?
Breaking, ma'am. The voice is breaking.
Okay, I think there's a network issue. So the advantages is polypharmacy we can avoid, airway manipulation. All these cause a significant stress during intubation, which can be avoided in this patient. Then it is advantageous, isn't it? Okay. Then what are the advantages of spinal anesthesia? What are the advantages of giving a spinal anesthesia over epidural?
In epidural, there may be a patchy.
Tell about spinal. You tell me about spinal first again.
Polypharmacy can be avoided. Multiple drug usage can be avoided.
Can be avoided. In epidural, there may be lost.
So spinal anesthesia, you have a definitive endpoint. You can use a low volume of drug. We have a definitive endpoint. So we have a dense anesthesia. What are the disadvantages? Then you can say that
Hypotension.
We cannot we cannot predict the level. Level it may become T12 also, and sometimes it can go high also. So that is one thing. Yeah, hypotension. Then
high spinal, total spinal.
We can predict the level. And it is of duration.
If
it is for a definitive duration. You cannot prolong it into the post-op. So what are the ways in which a spinal anesthesia, the duration can be prolonged?
Continuous spinal anesthesia.
Yes, continuous spinal is one. Can you use any additives?
Additives,
fentanyl
or
morphine.
So when you use fentanyl can prolong the effect, or what is the advantage of using fentanyl with the local anesthetic for spinal?
It
Increases the sensory blockade one.
It intensifies the sensory block and motor block. Okay, not the level, but with the lower volume of local anesthetic. So what it does, so it helps in providing a hemodynamic stability. That is the advantage of adding fentanyl to local anesthetic. We cannot prolong the duration, but we can have a certain extent of hemodynamic stability. Okay, that is the advantage of using fentanyl, not prolonging the duration. If you want to prolong duration, we have to use something like alpha-2 agonist that we can add to prolong. So if we add clonidine, what is the disadvantage?
Hypotension can occur.
Yeah, hypotension can sometimes be severe, and especially in geriatric patients, you cannot expect they cause excessive sedation also. So, okay, what is the advantage of graded epidural?
Hemodynamic.
We can maintain the hemodynamic stability, and we can give a segmental blockade.
What are the segments you want to block?
T10 to second.
So you first tell me what are the segments you want to block in this patient for this surgery, specifically.
T10 to S5.
How are you saying that one? T10 to S5?
Hip joint is mainly supplied by lumbar plexus and sacral plexus. Anterior capsule of hip joint is supplied by lumbar plexus, and posterior capsule is supplied by sacral plexus. In lumbar plexus, iliohypogastric nerve also. Iliohypogastric nerve supplies the.
So basically, this is what you're trying to say, that lumbar plexus is supplying the majority of the anterior capsule and these muscles also. Okay, therefore. So when we talk about the level, the segments to be blocked, in case of spinal, you should talk about the level. I want to block below T10. In case of graded epidural, the very advantage is the specific number of segments you want to block. So you should not say T10 to S5. So I want to mainly block the lumbosacral segments, isn't it? That is the basic advantage, that you can make it a segmental. I want a dense block at the level from, if you see most of the stimulus that comes, the incision is basically the femoral cutaneous, lateral femoral cutaneous nerve, which has a root value of L2, L3. For the muscles, it is the tensor fascia lata, the gluteal muscle, which is by either the superior gluteal nerve or the inferior gluteal nerve. Again, we have L4 to S2 nerve, which is the main root value of these nerves. For the anterior capsule, like what you said, it is the femoral obturator and the axillary obturator nerve, L2, L3, L4. Posterior part of the capsule is supplied by the nerve to quadratus femoris. This is one nerve which arises from the sacral. So that is L5, S1. So if you see the root value, basically we have to block between L2 to S2. Okay, that is, you have lumbosacral anesthesia, that is fine. Okay, so this is how you have to answer. For a graded epidural, I am going to block the lumbar and the sacral segments. And how do you conduct it? How do you graded epidural?
First, I will explain the procedure to patient. And
that's all done on the day prior. Now you conduct it.
In sitting posture, I will paint and drape.
Which position?
Sit. Prior to sitting position, I will give, if patient is complaining of pain, I will give a peripheral nerve block, like suprainguinal fascial block or pain block to relieve the pain. After that, in sitting posture, I will at the level of L4 and L3 and L4, I'll do I'll insert the needle and I'll keep it at the level of L1, L2. And I'll give local anesthetic test dose of 1.5% lignocaine with adrenaline 3 ml. And
After negative aspiration.
after negative aspiration.
So test dose of 1.5%, 3 ml, 45 milligram of.
Lignocaine.
So this will exclude what? This will rule out what? What do you want to identify?
Intravascular.
Intravascular or intrathecal placement of catheter.
How will you identify the intravascular placement of
Since this patient is on beta blockers, we can't see heart rate in rise.
No, what is the drug you said? You said lignocaine
With adrenaline.
with adrenaline. Okay.
Yes, ma'am.
So yeah, with adrenaline, how much adrenaline?
15 mics, 5 mics per ml.
Okay. Yeah.
15 mics.
So intravascular note by, since the patient is on beta blocker, continue.
We can't see rise in the heart rate. We can see increase in BP. If BP is 10 to 15 millimeters mercury increase, the catheter is in intravascular compartment.
Okay. Can we use adrenaline in patients with ischemic heart disease? This is a routine exam question. That's what I'm asking.
This is the minimal change here.
So only heart rate will increase around 10 to 15 beats per minute. If a patient is already on under 60 or 70 rates, this 10 rates will not increase hemodynamic changes. So we will give lignocaine with adrenaline to confirm the intravascular injection of catheter.
Yeah, personally, I am okay with this answer, but keep it in mind that there may be examiners who may oppose to using adrenaline for an IHD patient. I am okay with what you said. That is fine. You are going to look at the baseline heart rate and then you're going to give. But anyway, because the patient is on beta blocker, we are going to look at the pressure response, not heart rate.
Heart rate.
Right. What are the other test doses you can use?
Fentanyl we can use.
What do you observe?
50 to 100.
Yeah.
Patient may feel dizziness.
Okay. Apart from fentanyl, anything else? Injecting air and looking at the
precardial.
But we need a specific skill set to do the cardiac echo and detect it. Yes, this is there. Okay, but the best thing is always to aspirate before the injection. And every time you are giving a drug, you can
aspirate
test dose and aspirate and given 3 ml gradations. Okay, you have given 3 ml of test dose, ruled out intravascular and intrathecal placement. Next, what will you do?
And then I'll give spinal. Low dose spinal.
No, I am not asking the technique in this patient, your choice. I'm saying if you have to conduct a graded epidural alone.
Yes, ma'am. I position the patient in supine. Then first I'll calculate the dose requirement.
Over lumbar and sacral segments. You tell me the dose.
6 segments.
There are we have to block 6 segments. So 1 ml per kg.
1 ml per segment.
1 ml per segment. So we have to give 6 ml. First, I will give 3 ml of 0.3% bupivacaine and wait for 5 to 10 minutes. If the level is adequate, if the level is inadequate, then I will give 3 ml of 0.3% bupivacaine.
Yeah, one thing, 3 ml will be a small dose, isn't it?
Yes.
Established, you have given a test dose. You have ruled out intravascular and intrathecal. Another thing you can do is you can establish whether there's a segmental block that is achieved in this patient. So you have said my tip will be at L1, L2, isn't it? You can that level is blocked, isn't it? Then you can go for that 6 ml, what you have determined for use in this patient.
Yes, ma'am.
6 ml you want to use 6 ml. So that you have a block of what drug? 0.5% bupivacaine. What do you? Yes. So you use 0.5% bupivacaine, 6 ml, and after 10 minutes, you can start checking. Wait for up to 15 minutes to see whether the
Level is adequately taken.
If not, you're going to give another top up of another 3 ml.
3 ml.
3 ml.
Again as this. Okay. What is the advantage of doing it sequentially?
Hemodynamic stability.
Hemodynamic stability, and we will
Dose also
segmentally block the.
Yeah, so because you're segmentally blocking it, you can have hemodynamic stability, and the maximum segments blocked, I'm telling you, it will take around 10 minutes to 15 minutes.
Yes,
Fine, within 1 or 2 minutes. So the hypotension may occur in this also. It will progress slowly, and you have time to adequately manage it.
yes, ma'am.
Advantage of using a combined spinal epidural.
In combined spinal epidural, advantage over graded epidural is in graded epidural there may be sparing of sacral segments.
So we have the advantage of both spinal and the graded epidural in it. We can use a low dose spinal. So the problem of getting a high spinal, all this can be avoided, and then we can prolong the block by using epidural. Okay. The disadvantage is you cannot ensure that the epidural is in position, like what we discussed previously.
Graded egg well.
Suppose you see whether there's a segmental block, you give a graded dose. That advantage may not be there. So combined spinal epidural, the advantage is that you can give a low dose of spinal with a graded epidural and continue that in the post-operative period also. So the other technique you have is general anesthesia, either in combination with epidural you said, or a peripheral nerve block. So what is the technique you would choose for this patient?
I'll choose combined spinal and epidural anesthesia.
What is the position in which the surgery will be done?
Lateral position.
So what is another important determining factor on what is the anesthetic technique you're going to choose? If your surgery is 3 to 4 hours.
Patient comfort.
Patient comfort and the duration of surgery. That depends on in the place and the competence of our surgeons. If the surgeons can complete it within 2 hours, then fine. So depending on that, you're going to decide your anesthetic plan. Okay, right. So in your place, how much time do they take for doing the THR?
2 hours or 2.5 hours.
Okay, so your plan of anesthesia is?
Combined spinal and epidural.
Combined spinal epidural. Fine. Okay, now you have given a combined spinal epidural. You have given, how much spinal will you give?
I will give 10 milligram.
0.5%
hyperbaric breathing.
For spinal?
Yes,
spinal. And I'll check the level. If the level is adequate, I'll ask the surgeon to proceed the surgery. And
you will position the patient, isn't it?
Yes,
yes, ma'am.
Level. You're going to wait for the block to be established before positioning. What are the precautions you will take while positioning in the lateral?
There may be in a dependent arm, there may be brachial plexus compression and axillary vessel compression. So we have to adequately pad the dependent arm. And
patient is elderly patient, so we have to be careful on positioning when patient goes prone for fractures. And dependent area should be padded to prevent pressure injuries.
Dependent area means one half of the body is dependent.
On the shoulder blades.
Yeah, all the pressure points. The pressure points, and wherever you know that the nerves are running superficial, all these points have to be adequately padded. Okay. So, Priya, tell what are the other things?
Dependent ear, eye, shoulder, dependent shoulder, and hip bone, and knee.
Lateral flexion of neck can be occur. So we have to position the head in neutral position.
Neutral position. Arms?
Resting arm rest should be there.
So arms also should be in neutral position. You can use a double arm rest if your place has it. If you don't have it, no need to use. But you should ensure that hyper abduction is avoided in the dependent limb, and the non-dependent limb is positioned very comfortably. So now while taking IV access, which your patient is having a left side surgery, no?
Yes,
Yes,
ma'am.
ma'am.
Select for securing the IV line.
And securing the left side.
Dorsum aspect.
Dorsal
In the
aspect.
non-dependent side. Okay.
Yes, ma'am.
And what are the things? You will use an axillary roll.
Yes.
Make sure that axillary roll that is kept in the lower axilla to avoid compression of the major axillary vessels. So pressure padding, what are the neuropathies you can anticipate in the lateral?
Common peroneal nerve.
Yeah, common peroneal nerve in the dependent leg. Then the non-dependent leg, you can have compression of the saphenous nerve. In the head and neck area, what all nerves?
Brachial
plexus in the arm. Hyperabduction of the arm can cause brachial plexus neuropathy. Greater auricular, greater occipital nerve, all those on the side of the neck and the base of the skull. Okay. And the other important thing is a sudden change in position can cause
hypertension.
So to our intention should be to anticipate and prevent it as far as possible. We what are the measures we are going to take up is wait for the block to get established, see the extent of hypotension, treat it prior to positioning the patient by giving IV fluid bolus or a vasopressor inotrope, and stabilize the blood pressure before changing him. This patient particularly, he is on multiple drugs. He's on nitrates, he's on beta blockers, he's on calcium channel blockers. Then you can anticipate fall in blood pressure. If there's if the blood pressure comes down to 70 systolic, what will you do?
Heparin
3.
You have in front of you, you have positioned him. You positioned him, and now you see that the blood pressure has fallen down to 70.
Check for the level, ma'am. And patient is conscious oriented. I will feel for the pulse. The volume is low. I will give.
Yeah, first thing you're going to see is maintain communication with the patient. Whether the patient is conscious. Level will take time.
Yes, ma'am.
Whatever the level, our treatment plan should happen first.
Yes, ma'am.
Maintain communication with the patient, talk to him, check. So we'll come to know what is the level of his consciousness and those things. Check the pulse volume. Then
vasopressors like phenylephrine.
Then simultaneously, see what I'm saying, check will not happen at the next minute. All happen simultaneously. Consciousness, you're going to look at the heart rate. What is the heart rate? Whether there's a tachycardia or a bradycardia.
Yes, ma'am.
If there is tachycardia, what will you prefer?
Phenylephrine.
How much bolus?
40.
2 mL per kg.
40.
You can start with 20 bolus for phenylephrine. The same problem, that is what you said with beta blocker. We said that during test dose, there will not be an increase in heart rate. No? There will be an increase in blood pressure. But increase in blood pressure doesn't occur in patients who are not beta blocker, isn't it? When 15 mics of adrenaline is given intravascular. But it occurs more prominent in patients who are on beta blocker because the alpha effect is
upregulation of alpha receptors.
Yes, predominant alpha effect is there. So when we are giving these also, give 25 mics, look at the response and give a top-up bonuses. If the patient is, if the heart rate is less, it's around 45, what will you do? And a blood pressure of 70.
I will give atropine.
No, right? You said phenylephrine, which was a vasopressor, which has predominant alpha. Can you give something which can have an alpha and beta effect?
Ephedrine.
Yes, ephedrine. You can give ephedrine, mefentramin, all this which have both alpha and beta. And how much bolus?
6 mg bolus for ephedrine.
3 to 6 milligram bolus along and see the response. Repeat the dose. Simultaneously, you are going to give IV fluid bolus also. So while checking consciousness, you're also going to look at the way the patient is breathing.
Yes.
Why?
it is level is high, patient
Yeah.
will have expiratory
A labored breathing, axillary muscles will be active. So checking the level will take time, but just having a visualization of the patient's axillary respiratory muscles, the dilator nares, then sternocleidomastoid, scaling muscles, all this will give you a visual impression of whether the patient is high spinal or not. And that will determine what is the airway management you're going to do for this patient. If all this is not there, it's just because of a fall in SVR, with these managements you have done, patient will be fine, isn't it?
Yes, ma'am.
And I assume that you have given some oxygen supplementation using a nasal cannula or a face mask. Yes. Okay.
Ma'am, sorry to interrupt. Last
Yes.
5 minutes, we have some questions also to take up from the chat box.
Yes, sir. So shall I just tell what are the other questions?
Yeah, ma'am. Yeah.
So apart from this, we spoke only about the regional anesthesia techniques, but you should be prepared for giving a general anesthesia also for this patient based on the ejection fraction. How your drugs, how will you determine what are the drugs you're going to use for induction and maintenance? Okay. No, I'll just summarize it because of lack of time. If the EF is very low, less than 30%, you can go for a cardiostable drug like etomidate. Above 40%, propofol is a good choice, but give a sleep dose and make sure that hemodynamic stability is maintained. Advantage of using propofol is what? That we can have a good blunting of the airway reflexes and the stress response to laryngoscopy, everything can be prevented. Opioid of choice would be fentanyl. The relaxant, cardiostable one like rocuronium or becuronium. And the inhalation agent, sevoflurane is the best choice. But after giving all these drugs, you feel the blood pressure and the heart rate has come down, then we could choose to use desflurane, which is not suppressing the myocardium. Okay. So we spoke about the positioning. The other thing is the transfusion that you should know. You should be very clear on what is your transfusion trigger, and you have to calculate the maximum allowable blood loss for any patient who's posted and when you're going to start, and how much of packed cells will increase, how much of hematocrit when you administer it to the patient. There are two important surgical steps where we have to pay very important attention. One is the
reaming, femoral reaming,
and the second is the
implantation.
Bone cement implantation. So in when the patient is having hypotension with tachycardia alone, you could think even of bleeding. But if tachycardia with hypoxia is there, then you should think about embolism. What is the management? Administer 100% oxygen. 100%. We are going to use vasopressors, inotropes, and airway management accordingly. Steroids, there is no role. So far, there's no evidence. And what are the post-operative instructions? We have to adequately monitor the patient. MACE, whatever we spoke about in the preoperative assessment and risk stratification, was to detect all the major adverse cardiac events. So continue monitoring in a high dependency unit for 24 hours. Analgesics, you have to prescribe. If you are combining not only GA, you can give blocks even with spinal anesthesia. So that is, you're going to give it pre-op, not after the procedure, after surgeons have done manipulation of the joint, no, but prior to that, then you can have very good early postoperative analgesia. A pain medication, better to use paracetamol. And NSAIDs, depending on the renal function. Opioids, depending on the sensitivity of the patient and the requirement. So majority of the patients are okay with a nerve block and using a paracetamol alone. We should avoid shivering because all this causes an increase in oxygen demand. The next important question will be, how do you diagnose and manage a perioperative MI? Okay. Most of the, what are the perioperative MI, what you have already told is majority of the cases it is due to
endocardial ischemia.
That is principally because of a imbalance between oxygen supply and
demand.
Keep it in mind and monitor. If the patient is having an MI, you have to take a cardiology consultation. And because all the complications you have discussed previously during our pathophysiology, we said there may be so many complications in a MI patient, no? Yes. MR that occurs VSD. All these things, there can be a pericardial effusion. All these things can occur even in a perioperative MI if the thrombus is a mural thrombus. Okay. Other postoperative complications you should be prepared is delirium, then thromboprophylaxis, and we spoke about MI already. Delirium, what all you have to do to prevent it and how will you treat it? Other two questions. And if it is a fracture, it changes from the way from the initial period itself. The risk stratification to how much time we are going to wait will vary. Sir, Rajesh, sir?
Yes, madam.
Yes, so you can take over, sir.
Yeah, thank you. Thank you. Thank you, Dr. Kiruba and Dr.Sri. I'm having a feeling right now like coming out of an exam hall. Very nice discussion both of you gave us. And thanks to the postgraduates also for their contribution here. Now, there are certain questions, madam, in the chat box. Dr. Kiruba, you are there?
Yes, sir.
So okay, shall we take up the questions? Actually, the first question, this is from me only. There are a lot of scenarios where questions should be like echo, when to do. Like if there is a echo which has been done recently within some 2 or 3 months, should we have to repeat the echo again in this type of patients?
Yeah, yes, sir. I think as per the guidelines we go, if there is no new changes, like NVHA grade increases from 1 to 2 and patient is maintaining the same grade, there is no need for any new echo within 1 year. So, but if there is new symptoms like NVHA or angina increase from one grade to the other, or any other new cardiac events occur, then echo is indicated if the older echo is more than 1 year. This is what the guidance says, AHA. But due to it may vary as per the institute protocol also, because a few institute. Yeah.
If there is no cardiac symptoms, is it echo mandatory for age-related?
No, sir. If ECG, if your ECG is the first thing, if ECG is fine, there is no hypertrophy or no other ST or T wave changes, then echo is not indicated.
So that is
based on the symptoms also, sir. If patient is having symptoms of breathlessness and those things, that is the first indication of having an echo. Or if there is a murmur that is detected during the examination, then we can order for an echo.
No, in other way, the message for the postgraduate, it is not the age which determines whether echo is needed or not needed. It is all the functional capacity and the ECG change there. And okay, this is a question from Edward, sir. Does we need a stress echo cardiogram in this patient, or can you repeat the dobutamine stress test, Kiruba, again and highlight on that? Is it needed for this patient, stress echo?
Why we go ahead with the stress echo is that in this patient, the functional assessment is not possible. If we get an idea how much the patient can exercise, that means like how much he can increase his heart rate without any symptoms. That's what we want to know so that we can manage intraoperatively. If you think, if we get an idea, like if he's able to increase his heart rate up to 140 without any symptoms, we can allow this much, means like we can expect changes without any adverse events in the intraoperative period also. To get an idea of this, dopamine stress echo is really significant. But thing is that going for instead of coronary angiography, stress echo is much more. It gives much more idea in the perioperative management. One thing is that it also gives idea how much myocardium is at risk. If it is going to be a minimal, like regional wall motion obliterated 2 or 3 segments, it's not a big bother. But if it in case it involves the more LAD territory or more whole RCA territory, then yes, patient should undergo further coronary angiography and intervention is needed. So I believe that this protocol in most of the institutes also, like if the patient function status we are not aware, so better to go for a stress echo. So how to do this stress echo is pharmacology stress echo is that. So dopamine is started in a patient, in a resting patient who is not able to move around. So we can start dopamine. So dopamine started at the dose of 5 mg per kg per minute. So it is incrementally increased every 3 minutes. So from 5 mg to 10 mg, then 15, then 20, it can go up to 40 mg per kg per minute till we achieve a heart rate of 220 minus age. That is a maximum target heart rate. So if if the patient develops any anginal symptoms or a new LVB, then this test should be stopped in between. Even after giving 40 mg per kg per minute of dopamine, heart rate is not achieved, that means then we can try 1 dose of atropine. So it is similar to that. During the administration of dopamine, we should continuously follow the ECG changes like Holter, and also we should do the cardiac imaging. Either it can be a echocardiography, plain echocardiography, or a contrast echocardiography.
Okay, if this patient doesn't have any lower limb issues, will you subject him for treadmill test or?
Yeah, if he doesn't have a lower limb and he is able to ambulate, better is a treadmill test. So it give a better idea rather than a dopamine, because dopamine itself causes tachycardia. So this may be little side effect and kind of vasodilatory also. These effects can be avoided by physical stress alone. So treadmill is far better than dopamine stress in a patient who is able to do a treadmill test.
Okay, one more question for you. You were talking about some bridging therapy in these type of patients, and we stopped you when you are asking that question. So can you just highlight over the bridging?
Yeah, sure, sir. Sir, because the patient with regional motion abnormality, especially the akinesia, there are high risk of neural thrombus. So these patients may be on anticoagulation like warfarin for a long time. And also patient is an AF who is on warfarin, they cannot continue in the intraoperative period also. So these patients can be bridged over to another anticoagulant like heparin or low molecular weight heparin in the intraoperative period, because this warfarin T-half is longer. So this effect can last for more than a week. So once we stop this warfarin can be stopped 3 days at least before the procedure, and this period can be bridged over to heparin, and this heparin can be stopped 6 hours before the surgery. Once the surgery is over, so we can restart the heparin, and it can be bridged over with the warfarin during the post-operative period also.
This is for Priya, madam. From the previous point of view, if the surgeon wants to do bone cementing in these type of patients with ejection fraction of 38%, can we accept that answer, bone cementing, or can we go for uncemented hip arthroplasty?
Sir, in our RC, whatever the guidelines we have, the AHA-ACC guidelines, which is coming for ischemic heart disease for a non-cardiac surgery, the stepwise, when we follow itself, at a point when we see that this patient, how we can know his functional status is prior to the incident, whether his functional status was okay. That is what we are going to consider for this patient. So according to the guidelines, if we feel that the EF is low, the METs are low, less than 4, the METs are less than 4, then we have to take into consideration the patient factors and discuss with the surgeon of what will be the optimal management for this patient. So when we feel that there are plenty of risk, and then they can modify the technique. The surgeon may have considered on going for a cemented hip arthroplasty. But then after all this, looking at the patient factors and everything, they can come out with, we don't need to do a THR. We have another procedure for him. You go ahead with a non-cemented thing. Then at that stage itself, we should have a plan clear for this patient. This is what we are going to do.
Madam, there are some questions related to epidural doses. I think we can have that we can have it later and get the answer from you and put it in the online platform.
Yes, sir.
The answers, and there is one question related to another case discussion by Dr.Indra. So I think we can answer those from the chat box. I'll message you all those things from the chat box, and we can answer it separately.
Yes, sir.
And there is one question like, if the cardiologists usually give some risk assessment, some fitness, can we take that risk assessment as a thing, or we should have a separate risk assessment? Because many of
our risk assessment is basically on RCRI-7. The other thing is we have which we have ACS NSQIP risk calculator, which takes into consideration the surgery and plenty of patient-related factors. And we can come to know what is the percentage of major adverse cardiac events predicted for that particular surgery for these patient comorbidities. Based on that, we know this is the incidence of major adverse cardiac events. I think these two calculators are really simple and easy to follow. Only thing, the confusion occurs when we are not using it on a day-to-day basis. So if you start utilizing it on a day-to-day basis, then all steps go, it just follows sequentially and fall in place.
Yeah, in a simple way that cardiologists usually assess for life risk, while we assess it completely into surgical risk assessment. So
Yes,
for surgery, I think we should follow our own protocol.
our own calculators.
Cardiology fitness and this is especially for the postgraduates, because many a times they think that cardiology says it's mild risk, so it's a mild risk test. No, it is not like that. For our risk assessment is totally different.
Sir, our intention in getting a cardiology opinion is to see that we are giving a guideline directed medical treatment and patient is optimal prior to taking up for surgery. Like what we saw the stages of cardiac failure. They should clearly assess what stage of cardiac failure is the patient on. Does he need beta blockers? Do we need to add diuretics? Is it going to be so high risk that we cannot even take him up for any elective procedure? So these things we have to decide. This is what we need to get from the cardiologist. This is the condition. Manage him optimally so that we can take him up for an elective surgery if possible.
Some questions about nerve block. Can we give GA with nerve block, facial block catheter? Obviously, yes. I think Madam has already told, even with spinal anesthesia, we can give blocks. And certain blocks, there are newer updates with the hip surgery blocks, like the lumbosacral plexus block is still gold standard, but there are some other newer blocks like pain block and suprainguinal.
So primarily we have blocks like, so basically the nerves or the segments. When we talk about epidural, we have spoken about the segments. We need from L2 to S2 is the segments we have to block. But as these nerve roots come peripheral, we can either block them at the level of the plexus, that is in the psoas muscle, and the sacral and the lumbar plexus. That is very much skill dependent, and again, a deeper block will be a problem who is in patients who are on antiplatelet drugs. But as these go peripheral, then we have nerves, the individual nerves. We have the femoral, obturator nerve, and we can block them. That is quite easy, either as an individual nerve block or in the iliaca plane, which is what we call as the fascia iliaca plane block. Each of these has its own advantages and disadvantages. So as these nerves go even more peripheral, they become the articular branches. That is what we are trying to block with the PENG block. So it all depends where we want to block these nerves, either at the spinal or epidural or as a lumbar plexus, sacral plexus. We go peripheral, it is the individual nerves. When we go to the where it is supplying, it is the articular branches. So we have come out with techniques to block these at different levels.
This is the last question, Madam.
Dr. Rajesh sir, we are overshooting the time.
Okay.
So regarding this, before winding up, I want to highlight a recent advantages, the guidelines regarding the hip surgeries. This is in 2014, followed by a national audit of hip surgeries conducted in UK. There is anesthetic sprint audit of practice standard. They have released 12 standards. In the 12 standard, they describe what kind of anesthesia you have to give for high-risk patients for hip surgery. In the standard 3, they advise you have to give fascial iliac block for positioning the patient, then give ultra low dose spiral, that is less than 10 milligram. They can go for even 1 milligram, 5 milligram or 7.5 milligram with only one additive, that is fentanyl 25 mics, with an supporting epidural. So this is the guidelines they are saying. So thank you, Rajesh sir, for a wonderful discussion. And I thank Dr.Sri, Priya and Kirubanand. There is a wonderful blending of the theory and practical in this discussion. Rajesh sir, you have wonderfully arranged for that discussion. I thank Kirubanand and Sri Priya for the way they have taken that discussion. That theory part and clinical part, they have wonderfully blended both. Thank you, and thank you the postgraduates. We are with interesting topic. We have exceeded the time 20 minutes this week. That is no problem. We will meet next week with that. I thank the Acrola, the sponsors, and the host AIIMS Logics. Thank you, Nanda. We will meet next week. Thank you.
Thank you, sir. Thank you.
Thank you, sir.